All right, we are just past 8. Good morning, everyone, and let's start with today's nephrology grand rounds. We are delighted to have Dr. William Beaubien-Souligny from CHUM in Montreal to present to us on management of patients with AKI in the ICU. William is a nephrologist and a faculty at CHUM in Montreal. He has an interest in AKI, hemodynamic monitoring, as well as bedside ultrasound in this kind of a setting. He has research funding from FRQS, as well as he's a CRESCENT new investigator, I believe, from the Kidney Foundation of Canada. And he's already authored over 80 publications, peer-reviewed publications. And most importantly, he's got a CIHR grant on a trial of hemodynamic monitoring in AKI in the ICU that I believe Ottawa is also going to be a part of. So without much ado, please go ahead, William.
Thank you so much for the kind introduction, and thank you for the invitation to present today. I really like Ottawa. I've been recently there for the Tamarack race weekend, although they should call it the Ottawa Gatineau Marathon, because I think the race schedule was a lot in Gatineau too. But it's always a pleasure to come to visit Ottawa, and it's really close from Montreal. And I hope you, if you are coming to Montreal, we'll have the chance to discuss. So today my presentation will focus about the French here, the French title here. It's about fluid management in the context of severe acute kidney injury. So these are my disclosures. They are not relevant to the presentation today. So fluid management is a common topic in the ICU, particularly in patients with severe acute kidney injury. Here's a case just to begin the presentation. A very common case, a patient, 61 male patients admitted for a severe sepsis on acute cholangitis with pre-existing severe CKD. And after admission to the ICU, there's an administration of 6 liters of fluid during the initial resuscitation. And of course, he begins to develop severe acute kidney injury and becomes oliguric. And then there is the decision to be made to begin kidney replacement therapy. As you know, acute kidney injury is a very bad prognosis in critically ill patients, with severe AKI being associated with about a 40% mortality rate. And about 15% of survivors will remain on kidney replacement therapy long term. And when we take care of a patient and we prescribe kidney replacement therapy in this setting, fluid removal is always a critical component of this prescription, and that is one component that may affect patient outcomes. Severe AKI is associated with adverse outcome, and that may be related to the underlying severity of critical illness. But there's also other mechanism that may mediate adverse outcome in this setting. There is inflammation mediators. There is also urimate toxins. But one of the main pathophysiology that may lead to adverse outcome is fluid congestion, and congestion of different organs, including the lungs, but also systemic congestion of abdominal organs also. What are the impact of fluid overload? Well, first, elevated venous pressure lead to a reduction in the perfusion gradient and a reduction of the perfusion pressure of organs. And then also in the context of critical illness, there is an increase in vascular permeability, which leads to interstitial edema, which leads sometimes to an elevation in interstitial pressure, and that can commonly manifest through compartment syndromes, for example, abdominal compartment syndromes. And also it can increase the diffusion distance, and that can lead to tissue ischemia because of this, because of increased diffusion distance for oxygen and CO2. What are the typical course of a fluid balance in the ICU? When usually it has this shape for most patients with the initial phase of resuscitation, then following a stabilization phase and an evacuation phase. And sometimes the most important decision is when to transition from one phase to the other. So those hinge points, for example, the first transition when we decide that further fluid administration or accumulation is detrimental to the patient. And then the second transition point, well, when we decide that fluid removal will likely be tolerated and we can begin evacuation. And then also avoiding iatrogenic complication, so when to stop fluid removal and when to reduce the rate of fluid removal to avoid complication and to decide that the optimal fluid status for the patient is reached. So what will be improving fluid management? Well, we can think that first we would want to limit the severity of the initial fluid overload. And that comes through the timely detection of a congestive state, but also maybe limiting the duration of fluid overload and organ congestion, and also identifying the optimal timing to initiate fluid evacuation, while also limiting the iatrogenic fluid depletion in hemodynamic instability that may also mediate adverse outcomes. So in epidemiology, there is a clear association between cumulative fluid balance at the time of renal replacement therapy initiation and mortality in the ICU, and also the time during which fluid overload persists is also associated with an adverse prognosis. This is the initial data from José Bouchard, who is a nephrologist at CIHR Hospital in Montreal, but that was validated in multiple cohorts since then. There's also some observational data that suggests that improved decongestion after the initiation of renal replacement therapy is associated with improved prognosis. And then this is data from the renal study which was done in early 2000s, randomized controlled trial on the dose of dialysis. But then in this data, patients who were decongested early within the course after initiation of CRT had a better prognosis. In this case, we're talking about fluid balance, so the in-out of the patient. But of course, you know, fluid balance is a difficult topic to study with observational data because, of course, patients who received a lot of fluid early in their ICU course are typically more sick than patients for which a restrictive fluid balance management is possible, broadly speaking. So there may be some residual confounding explaining the epidemiological relationship between positive cumulative fluid balance and adverse outcomes. And some data highlight this potential doubt on the fact that a positive fluid balance in the ICU is truly a mediator of adverse outcome. For example, in the START-AKI trial, in which renal replacement therapy was begin in an accelerated fashion versus a more conservative approach, where the patients were, we waited for 72 hours or until absolute indication arise to begin renal replacement therapy. You see that for patients who initiated renal replacement therapy, you see that in the standard strategy group, there was accumulation of fluid greater than in the accelerated strategy group. And as you know, if you're familiar with the START-AKI trial, you remember that there was no mortality benefit for an accelerated strategy in the START-AKI trial. And during a reanalysis based on the fluid balance, cumulative fluid balance at the initiation of renal replacement, at the enrollment, in the trial, you see that there was no mortality benefit in the fourth quartile of fluid balance. So even if we take into consideration the initial fluid balance of the patients, this did not change the conclusion of the trial. There are some caveats to that because patients enrolled in the START-AKI trial, there was some pre-existing conditions. So the inclusion in the exclusion criteria of the START-AKI trial made it so that if the intensivist believed that the renal replacement therapy was indicated and could not be delayed, those patients did not participate to the START-AKI trials. And for some intensivists, fluid overload represent an absolute indication to begin renal replacement therapy. So the patients with the most, which were the most congested in this population were likely not recruited in the START-AKI trial. The other evidence-based medicine that is interesting to review is recent trials on fluid resuscitation. For example, the classic trial in the Clovers trial in the patients which presented with septic shock or sepsis. A very big multi-center randomized clinical trial that compared a restrictive approach to a more fluid liberal approach. And in these trials, there was some difference in cumulative fluid balance, about 2 liters in both trials, but there were no difference in patient outcomes, which also bring out the doubt that maybe fluid overload is not a mediator of adverse outcome maybe in this population. And of course, in patients with kidney replacement therapy, well, there is the potential adverse effect of organ congestion, but we must balance that with the potential effect of hemodynamic disturbances related to fluid removal. And while I was in my fellowship in Toronto, we studied whether the hypotension during the first intermittent renal replacement therapy performed in the ICU was associated with mortality, and we found that hypotension was independently associated with hospital mortality in this setting. And one of the most important risk factors for that was the prescribed fluid removal in relationship to body weight during the first intermittent renal replacement therapy, usually after the transition from continuous renal replacement therapy. There is also a rising literature regarding high ultrafiltration rate on CRT that has been associated with mortality in multiple cohorts. So it's usually the Dr. Mergen group from Pittsburgh that has shown in multiple cohorts that high ultrafiltration rate seems to be associated with mortality. But then in this literature, we're usually not talking about fluid balance. We're talking about net ultrafiltration, and net ultrafiltration in this setting is the in-out of the CRT machine. So you may understand that if the patient has a very severe critical illness, he may receive a lot of IV medications, and that may lead to higher net ultrafiltration requirements. So that's something that may induce some bias in the data. Although a recent analysis showed that if we take fluid balance into account using mediation analysis, the effect is attenuated, but the effect of high net ultrafiltration still seems to be associated with adverse outcomes in critically ill patients. So, of course, there is a paucity of randomized controlled trial on the topic of fluid balance management, and particularly in the settings of patients that we are receiving kidney replacement therapy. There is no conclusive trial on the topic, which leads of course, to unclear recommendations from current guidelines. That is, for example, the KDIGO guidelines that date back for a decade ago say that we should provide RRT in critically ill patients to achieve the goals of fluid balance that will meet the patient needs. And that's not clear what that represents. We recently performed an international survey among intensivists and nephrologists all over the world, and it has been recently published in CGSN in early 2023. And this effort was led in great part by my master degree student, Lawrence Ledoux-Hutchinson. And we asked intensivists and nephrologists what were the priority when prescribing fluid removal in patients receiving kidney replacement therapy in the ICU. And as you can see on the screen, most participants believe that achieving a rapid decongestion after initiating kidney replacement therapy was a clinical priority. But perhaps a little bit paradoxically, most respondents also agreed that we should prevent the occurrence of intradialytic hypotension and that this should be prioritized. So that represents the conflict between the two priorities, the conflicting priorities of achieving rapid decongestion, but also preventing hemodynamic instability and intradialytic hypotension during the prescription of fluid removal. So fluid management is a complex intervention, and it's not just prescribing a fluid removal rate. It's more complex than that. We must first assess fluid volume assessment, so assess the fluid status of the patient and determine what will be the optimal fluid status in order to have a clear target to reach. But there's also, after that, the process of actually reaching this target, so a fluid removal strategy that will be safe and that is implantable and feasible in daily care. So I will first talk about the evaluation of fluid status. Evaluation of fluid status in the setting of critical illness is integrating multiple sources of information. And sometimes it can look like this. This is the blind man's and the elephant. And sometimes we have different sources of information, and that leads to different conclusions about the fluid status of the patient and the optimal target to reach. I've talked a lot about cumulative fluid balance, but there is severe limitation about cumulative fluid balance in the ICU. So this is, for example, data from the START-AKI trial, and I'm showing this to demonstrate that if you add up the daily fluid balance for a few days in the ICU, you will notice that you will quickly ends up with implausible fluid balance. For example, in the START-AKI group, you see that after 14 days, you see that some patients were deemed to be to have a cumulative fluid balance of more than 34 liters, or being negative minus 20 liters. And of course, this is a number, but we of course know that this is probably implausible, and the cumulative fluid balance after a few days become imprecise because of all the fluid lost that are non-quantifiable, and that is a significant problem in this marker when we use it in the ICU. So there is also other sources of information, some more traditional and some new, potentially new source of information. For example, we can assess, for example, total body water and extracellular, intracellular fluid distribution. And the traditional way to do it is to follow, for example, body weight of cumulative fluid balance. But some new ways to do it will be, for example, to applying electrical bioimpedance to assess those more precisely, those compartments. There is also the potential to assess whether an organ specifically has interstitial edema or as congestive, at risk of congestive organ injury. And that could be traditional methods, for example, just doing a chest X-ray, looking for pitting edema on the legs or peripherally. And some additional markers that we'll talk with, for example, lung ultrasound that can identify B lines, which is a marker of lung congestion, but is non-specific in the setting of critical illness. I'll return to that shortly. Venous pressure, so we can monitor venous, look at jugular veins. We know the caveats of that as we are clinicians, and we know that it is very hard to do in some patients. And of course, in the ICU, there is central venous pressure measurements through central catheters, but we also know that this can be modified by mechanical ventilation, and also the transducer placement can also modify the values, and that can sometimes tricky to obtain precise measurements. And there is some adjunct method that I will talk about, for example, venous Doppler assessment. And then also there is circulating blood volume. For example, in the ICU, we could look at arterial blood pressure, of course, but also cardiac output monitoring and blood volume through, for example, intermittent renal replacement machine. So the hemodialysis machine, some will output some relative blood volume measurement that may be useful when performing renal replacement therapy in the ICU. So during our survey, we asked which source of information you typically use in your assessment of the patient on KRT in the intensive care unit. And you see all the proportion that is right of the orange line here is method that the respondents use at least once a week. So you see that most patients look at cumulative fluid balance and repeated weight measurements. And there's also an increasing number of respondents that look at ultrasound markers and hemodynamic monitoring markers. And of course, we also determine that nephrologists are less likely to, for example, use ultrasound in hemodynamic markers than intensivists in their evaluation of fluid status. Now I will talk a little bit more about ultrasound markers of fluid status. So as I discussed a little bit briefly before, we can perform a lung ultrasound, which has been studied in the setting of chronic dialysis, where it can identify the presence of pulmonary congestion, even when it is asymptomatic. But the problem in the ICU patient is that a lot of patients have ventilator-associated pneumonia, atelectasis, partial atelectasis. Some patients have pneumonia. Some patients have ARDS. So these conditions can lead to pulmonary B-line. So there is a lot of confounding factors as a pure marker of fluid balance status here. There is also the identification of effusions. So this is a pleural effusion that can be readily identified by a point-of-care ultrasound. But again, this is non-specific and can also occur because of multiple factors in the ICU. There is the IVC. So this is a dilated and non-variable IVC during the respiratory cycle. And this is usually associated with central venous pressure higher than 10 to 12. But that does not tell us if the central venous pressure is severely elevated. So if the patient has a CVP of 10, or it will look like this. But if a patient has a CVP of 24, it will also look like this. So it's generally considered to be inadequate for the precise assessment of fluid balance status. And then there is the obvious signs of right ventricular failure on cardioechography. So here you see that the right ventricle is pushing against the left ventricle, but in a significant proportion of patients in the ICU, transthoracic ultrasound is hard to do, and this is only a severe case. So some more subtle forms of echographic markers could be used for aiding in fluid balance management. That's sometimes difficult to do in the ICU patients, and there are some caveats that I will not go through in details during this presentation, but there is limitation associated with this type of assessment. So let's talk a little bit more about the venous Doppler assessment. So what we can see on venous Doppler, usually in the normal patients, that is not congested, is that usually in the circulation, venous pressure is variable only through the CVP waveform. So you remember that the X and Y descent on the CVP waveform is associated with venous return in systole and in diastole, which produce variation in the venous Doppler when we assess it close to the right atrium. For example, in the hepatic vein, it produces a triphasic waveform, as you see here on the screen. But if you go more peripherally, for example, in the intrarenal venous Doppler or the portal vein, usually the venous Doppler signal will be monophasic without great variation during the cardiac cycle. And when the patient becomes congested, well, usually the normal venous compliance is alleviated and the venous network become rigid. And then first, the pattern of venous return during the cardiac cycle change, and the venous return to the heart happened more in diastole than in systole. That's the first change. And then after that, when the venous system becomes non-compliant, those variations in venous pressure are transmitted backwards in the peripheral veins, and we can detect this as pulsatile waveforms in the organs and in the distal organs and distal veins of the body. So one of the easiest site where we can assess these abnormal waveforms is the portal veins. So you see on the left portion of the screen a portal vein that is normal, that is continuous during the cardiac cycle. And on the right portion of the screen, you see a pulsatile portal vein that is evident here on the color Doppler assessment too. When we assessed intrarenal venous flow, this is the normal pattern with the waveform below the yellow line being continuous during the cardiac cycle. And as venous congestion developed, these waveforms begin to appear discontinuous with flow both in systole and in diastole. And after that, when it is severe, there is flow only during a brief portion in diastole. So this is the severe pattern on the renal Doppler assessment. And this is something that is dynamic. So this is an example using transgastric renal ultrasound during off-pump cardiac surgery that we assessed a couple of years ago. So you see during the first portion of the case, the renal vein is monophasic, and then the patient develops right ventricular failure and the renal vein becomes pulsatile. And then after some interventions such as IV nitroglycerin and IV intrapulmonary vasodilators, you see that the venous flow in the kidney become non-pulsatile again. So it is dynamic and respond to interventions, at least during cardiac surgery. So during my PhD, I studied these types of venous Doppler markers, and we built a research program around it at the Montreal Heart Institute and now at the CHUM. And we studied it in cardiac surgery. We proved that it was associated with other markers of venous congestion, such as, for example, natriuretic peptide, and it was associated in the setting of cardiac surgery to AKI and major complications. And then we developed something we called the VEXUS method that we'll talk about it in the next slides. And then we're beginning to apply it to severe AKI right now. So what is the VEXUS assessment that you may have heard about on social media and in conference? Well, during our initial studies, we found patients where the signals were discordant. For example, there was some patients, healthy patients, sometimes, for example, in healthy volunteers that came to ultrasound workshops, medicine students that were running multiple kilometers a day, for example, that were exhibiting a pulsatile portal veins, but the other signs, the other sites of assessment, for example, the hepatic veins and the intrarenal venous flow was normal. Another type of discordant signals was the patients with severe tricuspid regurgitation, but that were treated appropriately and was not very congested. So those patients may have an abnormal hepatic vein, but the other venous Doppler signals were normal. And finally, the critically ill patients, sometimes the renal Doppler assessment is very challenging to do. So sometimes they can lead to suboptimal Doppler waveforms, and then that could be misinterpreted as abnormal waveforms. So there's patients that had a very bad Doppler waveforms, but the other waveforms were normal. So since with those observations, we used our previously acquired data to validate a system, a grading system that we named VEXUS. And the basic concepts of this system is that we first assess whether the IVC is consistent with the presence of ICVP. And if it is the case, we moved on to the VEXUS, the venous Doppler assessment. And if there is only one of these markers present, we say that it is possible congestion. But if there is more, 2 or 3 of these markers present, we assess it as probable congestion. So we validated this assessment using cardiac surgery data, and we saw that the VEXUS grade 3 was significantly associated with the AKI in this setting. And of course, this is limited because that's been only validated in patients with cardiac surgery. But then we recently applied it to patients who had severe AKI. So the Eco-AKI study that we recently finished, but is not yet published right now. We assessed the VEXUS markers in patients with severe AKI in the ICU. This was a prospective cohort study with patients with AKI stage 2 and up. And we performed ultrasound evaluation at enrollment after 72 hours and after 7 days. And we assessed whether those abnormal venous Doppler signals were associated with major adverse kidney events, which is a composite outcome of death or persistent decrease in kidney function at 30 days. And we also assessed whether the individual components where outcomes were associated with our markers. And so that includes all-cause death. And also we assessed whether it was associated with ICU length of stay. So in the Eco-AKI study, we enrolled 125 patients, and those were critically ill patients. So most of them were receiving mechanical ventilation, and most of them were receiving also vasopressor support. And the cumulative fluid balance at enrollment was 5.1 liters. So that were patients who, for the most part, had received a significant fluid since their ICU admission. So as you can see, there was a significant proportion of patients who presented with significant venous Doppler markers, but those prevalence were a little bit less important than in cardiac surgery. For example, as you can see, there was in overall assessment, there was about 10% of patients who present severe VEXUS grading during the assessment of the study. So that's a little bit lower than the 15 to 20% we typically see in cardiac surgery patients. As you can see, as time gone on, the number of assessments significantly decreased over the study period because either patient died or they were discharged from the ICU, and then they were not assessed after that. So because we saw that in relationship with our primary outcome, which are major adverse kidney events, we saw a trend toward adverse outcome with our abnormal venous Doppler markers, but this trend did not reach statistical significance, as you can see here, for VEXUS or for individual venous Doppler markers. However, if we make the association with all-cause mortality, patients with a VEXUS grade of 3 was associated with more death at follow-up after enrollment, as you can see here on the Kaplan-Meier plots. And when we adjusted for baseline characteristics, including, for example, baseline comorbidities, but also severity of illness, for example, the receipt of vasopressor and mechanical ventilation, both grade 2 and grade 3 was associated with higher ICU death, so associated with all-cause death at 30 days. And also individual markers such as abnormal portal vein Doppler, abnormal hepatic vein Doppler, and abnormal intrarenal vein Doppler were all associated with mortality. So the conclusion of the study is, while it is the abnormal Doppler markers were not associated with major adverse kidney events, so there were no association with persistent decrease in kidney function at follow-up, but there was an associated with all-cause death that is significant. And so that we can maybe infer that the presence of those signs are maybe could be used to identify patients who are at risk of adverse outcomes, and that those adverse outcomes could be mediated by venous congestion, although this is hard to demonstrate formally. This is a case just to see you some practical case that we saw during the study. So this is a patient after cardiac surgery with a cumulative fluid balance of 5 liters, and this is at CRT initiation, while the patient after the patient had developed severe AKI. And this is the portal vein that is normal after 6 liters of fluid removal 72 hours later after the initiation of CRT. So this is just a proof of concept that maybe the repeat assessment of these venous congestion markers could help us tailor therapy in patients with severe AKI. But of course, these observational studies are not sufficient because, we, as I showed you earlier, demonstrating that a marker, either cumulative fluid balance or those Doppler markers are associated with adverse outcomes are not sufficient. We must determine that this complementary information combined to other source of information results in a modification of management in these patients, and that could improve prognosis. And in the early stages of designing a randomized clinical trial, our original ideas was to outline a fluid management protocol based on these ultrasound markers. But we quickly realized that if we wanted to remain with a wide inclusion criteria in this study, we couldn't come up with a detailed protocol that will take into consideration all the situations that we can find in the critically ill patient, which is really a dynamic situation. So we took the devil advocate approach, saying that, well, maybe volume assessment is not the primary problem, although we think that there is severe problems with our volume assessment right now. Maybe we can focus for now on the fluid removal strategy and a way to effectively and feasibly implement it in daily care. And we focused on those, on the remaining 3 puzzle pieces of the fluid balance management in critically ill patients with severe AKI. And I will go through them sequentially. First, fluid stewardship. After that, pharmacologic strategies. And after that, ultrafiltration strategies to improve fluid balance management. So in our survey, we asked around about who were managing fluid removal on CRT and on intermittent hemodialysis. And perhaps unsurprisingly, we found that for CRT, usually intensivists were the one prescribing fluid removal, but for intermittent HD, then it was much more balanced with in most centers, this was the nephrologist prescribing fluid removal, but in a significantly proportion of centers, this was also a shared decision among intensivists and nephrologists. So after the first few days of ICU admission, we often don't realize that the main source of fluid may be maintenance fluid, drugs, and nutrition. So you see that this is a cohort study in outlining the source of fluids between day 3 and day 7 after ICU admission. And you see that the greatest proportion was maintenance fluid and nutrition. And there is the concept of fluid creep, that after a few days, most of the source of fluids may be hidden or might be coming from other source, and the resuscitation fluid are a relatively minor source of fluid after the first initial resuscitation phase. And this group have shown that maybe with theoretically, when applying fluid stewardship policies such as concentrating drugs, concentrating nutrition, and making sure that we avoid maintenance fluid that is unwarranted, there is a theoretical reduction of more than 2 liters per patient of non-resuscitation fluids that could be achieved. So what are the fluid stewardship principles when it's concentrating drugs? Using an enteral nutrition formula that is concentrated, usually renal formulas, avoiding maintenance fluids when not indication, and using principle of fluid responsiveness while applying boluses to hemodynamic optimization. And in our survey, we saw that usually those principles of fluid stewardships in most centers are not ingrained into usual care for now. So that's potentially a target for improvement. The other potential strategies are pharmacological strategies. So there has been a couple of pilot trials looking at whether the early use of diuretics can lead to a reduction of cumulative fluid balance management at follow-up. For example, the RADAR trial, which was focusing on active deresuscitation using diuretics, and also the reverse AKI trial, a small trial in AKI patients not on kidney replacement therapy that showed that the fluid restriction bundle, restricting fluid input, but also using diuretics to aim for an negative fluid balance, was also effective to induce a greater negative fluid balance than in the usual care group. We also asked ourselves what was the diuretic strategies the most effective to induce the negative fluid balance. So my colleague Jean-Maxime Côté from the CHUM and myself, we performed a retrospective analysis of the MIMIC-3 cohort, which is a large ICU database in the United States. And we compared diuretic strategies in patients who had at least 1 milligram per kilogram of furosemide a day in the ICU, and we found out that perhaps using a continuous loop diuretic infusion or adding a thiazide diuretics was associated with a greater negative fluid balance, even when adjusting for the total dose of furosemide given. So those are potential pharmacologic strategies to optimize fluid balance in patients before KRT initiation, or even if the patient has a significant urine output, to use when the kidney replacement therapy has already been initiated. So that's data that I've already shown. So another important concept is the concept of how we prescribe fluid removal and fluid balance target in the ICU. So I don't know how it is done in Ottawa, but at the CHUM, typically the intensivist on CRT will prescribe a net ultrafiltration rate. And for intermittent renal replacement therapy, it's the nephrologist that will prescribe net ultrafiltration as a number of liters for a particular hemodialysis session. But maybe we should instead prescribe a 24-hour fluid management goal. So that's something that it is done, for example, in the UK. This is data from Dr. Osterman group in the UK that show that in their units, they usually prescribe, they really prescribe a clear fluid target balance, daily fluid balance target for each day of ICU stay. And you can say that for patients for which the clear fluid target is prescribed for each day of CRT, the mortality rate seems lower. Of course, there are some caveats to this data because, of course, over the patient that for all their ICU days, there was no clear fluid balance target. That might be because the patient is too unstable and this can lead to an early death. So that may explain why in patients who had no prescription of ICU daily fluid balance, the mortality rate was very high. But another interesting data from this study was that even if there was a clear prescribed fluid target, it was only reached in about half of CRT days in the ICU. So that may represent improvement target. Our colleague Javier Nera from the United States also published that maybe we could take note of the difference between the fluid balance goal for each ICU day and the fluid balance achieved. This is specifically on continuous renal replacement therapy, and identify which is the gap in fluid balance management. And of course, as showed in the data from Dr. Osterman in the UK, the greater gap is associated with adverse outcomes, which may be related to multiple factors. Some may not be modifiable, but this metric should maybe be kept under watch, and maybe there are some modifiable factors that could help us attain our goal of fluid balance management in the ICU. There is also a great controversy about what represents a safe net ultrafiltration to target in the ICU. This is data from a survey that said that there is no consensus on what represents a safe maximum fluid removal rate on CRT or on intermittent hemodialysis in the ICU, with some practitioners limiting fluid removal to 1 to 2 liters per day of negative fluid balance per day, and some practitioners being very aggressive, sometimes targeting even greater than 5 liters of negative fluid balance per day, either even on CRT or on intermittent renal replacement therapy, which is a very aggressive decongestion. We know, as nephrologists, we know a little bit of the literature in CKD that shows that high ultrafiltration rate on intermittent renal replacement therapy is generally associated with adverse outcomes, and this association becomes significant, usually higher than 10 milliliters per kilo per hours of treatment of net ultrafiltration, as Dr. Flight showed in the chronic dialysis population. And when we ask what is the preferred strategy when, for example, the ultrafiltration requirements is not reached by doing 3 sessions of intermittent hemodialysis in the ICU, and as you can see, the strategies are varied, with about an equal proportion of respondents saying that they use, for example, SLED, so prolonged intermittent sessions, frequent daily sessions, or a switch to CRT when it is possible to alleviate the high ultrafiltration requirements in patients on intermittent renal replacement therapy in the ICU. So to recap, so the other components of improving fluid balance management in the ICU is minimizing fluid intake and using pharmacologic strategies to diurese and to reduce ultrafiltration requirements. Of course, a daily reevaluation of fluid management goals and setting targets and choosing the appropriate modality and co-interventions. And of course, there's much to do to determine what represents safe targets, the proper modality, and the best co-interventions to promote hemodynamic stability in patients on CRT and IHD in the intensive care unit. In our survey, we saw that most respondents agree that it is ethical to perform trials on fluid management in critically ill patients with AKI on RRT, and I think it is the only way forward, as we discussed. Observational data, both on cumulative fluid balance, fluid overload, but also on hemodynamic instability on renal replacement therapy. Those observational data are highly confounded, and probably that only trials will give us what is the optimal fluid balance management in this setting. So we are trying to make the first step in this endeavor. And we recently began the probe fluid trial, which is comparing a proactive prescription-based fluid management strategy to usual care in critically ill patients on kidney replacement therapy. And the question is to determine if this approach compared to usual care will result in a significant separation in fluid balance between arms, and to know, of course, if this trial is feasible. So it's a pilot open label multi-center randomized clinical trial in about 10 to 15 centers in different countries, and we aim to enroll 150 participants. We begin in May, and we have so far recruited about 1 patient per week, so we have 4 patients recruited right now. And the inclusion criteria is adults, patients admitted to the ICU and for whom there is a planned initiation of renal replacement therapy within 12 hours, or if the patients have received KRT but for less than 48 hours. And then the exclusion criteria is patients who will, for the intensivist or the attending physician, think that there will be a change in the goals of care, discharge from the ICU, or death within 48 hours. And we will also exclude patients with severe burn injury, severe dysnatremia, and also ongoing fluid losses that are expected to require continued maintenance IV fluid during the next 48 hours. And these might look like this, for example, massive GI losses, continuous ascites drainage, massive surgical drain outputs, or severe active bleeding. But that may be a temporary criteria because once the bleeding is stopped, the patient could be reassessed for the participation in the trial. So we decided to exclude severe burn patient because in our survey, about half of the respondents reported that they would not be comfortable enrolling those patients in the fluid balance management trial because cumulative fluid balance is difficult to assess because they lose so much fluids from the wounds. So we will randomize those patients between protocolized fluid removal and usual care for 5 days, or until kidney recovery. That is, if the urine output allows for to reach the fluid management goals, or until ICU discharge, and then the patient is returned to usual care. And then the intervention will be based on 3 steps. So each time, for every day of the 5-day trial, there will be step 1 where the physician will define a 24-hour fluid balance target. Step 2, where the physician will prescribe fluid removal using kidney replacement therapy. And step 3, where we perform fluid stewardship, so reevaluate all forms of fluid intake for that is going in the patient. So these are the outcome of the study. So the primary outcome will be cumulative fluid balance from randomization to the end of day 5, and there will be a number of secondary outcomes, including feasibility outcomes, clinical outcomes, resource use, because intervention may use to greater use of renal replacement therapy, safety, for example, hemodynamic stability and adverse events related to renal replacement therapy, and process measures, for example, outlining the decisions of the physicians in the intervention arm that will be captured in the prescription form. So we expect a recruitment rate of about 2 patients per month, and they can be co-enrollment, and the ongoing trials will be frequently reviewed if co-enrollment is permitted. So I just want to briefly show you the forms that would be used for the trial. So this is the main form that is filled once a day, that where the physician decide if there is we aim for a negative fluid balance, or if we aim for a neutral fluid balance for the day. If we aim for a neutral fluid balance, the physician must precise if they chose this option because they think that fluid accumulation is minimal, or fluid accumulation is present, but net fluid removal is contraindicated at the present time. After that, we will capture all the elements that contributed to decision about fluid status of the attending physician. And then there will be a fluid stewardship checklist, checking that all IV medication are given in the least amount of fluid possible, the feeding is concentrated, and the maintenance IV fluid are stopped. And then after that, it is prescribing the fluid removal. So we will prescribe the fluid removal and continuous renal replacement using this form, which adjusts the net ultrafiltration rate based on the target. And we ask to define safety threshold at which ultrafiltration rate is reevaluated by the attending clinician, and what to do when these safety thresholds are exceeded, to give a clear instruction for the attending nurse to determine what they must do when the safety threshold is reached. And then if intermittent hemodialysis is considered, well, there will be a form to determine whether it is reasonable to expect that the fluid removal during the session will be sufficient to obtain the fluid management goal. And if the net ultrafiltration rate exceeds 8 milliliter per kilo per hours, we will ask for the attending clinical team to reassess the fluid, the kidney replacement strategy, either by increasing the duration of intermittent renal replacement therapy, the frequency of sessions, or switching to CRT. So depending on your local practice, which I think in Ottawa might be SLED, you can choose whatever is the most reasonable option for your centers. So there is other considerations. For example, after 5 days, the fluid prescription template is no longer obligated, but if in the intervention group, the physician want to keep using it, they can. If for example, the urine output increased and then you don't have to do any more UF and the patient don't need dialysis anymore, then the RT can be discontinued, and then the fluid management prescription forms don't need to be filled anymore. And then the other question that we frequently have, if after enrollment, well, the attending physician might consider that the fluid bolus is indicated, and this is fine. We just want to avoid maintenance fluid. So for example, the attending clinician want to give a bolus, they must prescribe it as, for example, 1 liter of normal saline in 4 hours and then stop the infusion. So this is prescribed to avoid maintenance drip that lead to fluid creep and that are forgotten sometimes by the attending care team, and that leads to fluid accumulation or greater ultrafiltration requirements. So I want to emphasize that it is only the first step in uncovering the optimal fluid management strategy in the intensive care unit. You know that there could be multiple questions to ask after this trial focused on feasibility. For example, we ask this in our survey, and you know there could be the question on how fast fluid should be removed, what markers can we decide to when to start or stop fluid removal, when fluid removal should be initiated, early versus deferred, and we can ask ourselves whether we should increase vasopressor support in some patients to permit fluid removal, so a vasopressor liberal versus a vasopressor sparing strategy. So there's a lot of work to be done in this field, and the ProFluid will set the background and assess feasibility of doing a trial in this topic in the ICU. So this is the conclusion of my presentation. So there is multiple domains left to explore, as I said, and I hope, despite the significant uncertainties on this topic, I hope that I spark your interest and that you will be aware of the major issues and questions left unresolved about fluid balance management in the ICU. Thank you so much for your attention.
Thank you, William. That was a wonderful, thorough presentation on fluid balance. If you want to see our faces, you could, stop sharing so you can see who else is around. So if people have questions, we do have a few minutes. If anyone wants to raise their hand and ask a few questions, please go ahead. Oh, Todd, go ahead, please.
Thanks, William. That was a great. Quick question, and I might have missed this. The venous Doppler monitoring, is that something that can be taught, and how is the kind of inter-user variability there? Like, is this something that residents can do, or do we need radiology to help?
Radiology don't tend to be interested in this because that involves interaction with the heart. So like cross-organ interaction, radiologists are not comfortable doing this usually. Cardiologists might be more interested in doing this assessment. It is an intermediate point of care ultrasound technique. It is teachable. A lot of fellows, and general internal medicine fellows, nephrology ICU fellows are able to do it. in the ICU, the main concern is the intrarenal venous Doppler is very hard to do. In fact, the failure rate is about 25 to 30%. So we are right now studying alternative sites of assessment, for example, the femoral vein, which could be easier to assess. So that could be an interesting option. And for answering your questions, in operators that have experience doing it, the inter-observer variability is generally good. So for portal vein, hepatic vein, when we have ECG monitoring, and to determine the pattern of intrarenal venous flow, when assessing through experienced operators, the inter-observer variability is generally good.
Thank you.
Yeah, thank you. That's really good to know. I think Ted Clark has a question from the conference room.
Hi, William. Thanks for a great talk. Couple questions here in the conference room. I think David had a question.
Okay, merci beaucoup, William. So great presentation. And regarding your probe study, it's at the step 1 where there's the setting of the daily fluid balance goal. And that kind of made me think of the slide you had presented earlier from the UK data where they showed the improved mortality when you can even set a daily goal. And so, you know, I'm sure you thought of this, but, you know, you're probably going to be including much more stable critically ill patients. And perhaps maybe that's your goal, just to see if the fluid prescription, protocolized prescription works in those patients, and then see if you can set it to other more critically ill patients. But do you wonder about that limitation for maybe more limited generalizability, or do you have a plan to maybe take it to the next step after the first part, the feasibility?
Yeah, we plan to enroll patients relatively early after renal replacement therapy initiation. So we want the patients to be pretty sick. And we, you know, in the form, we also plan that updates can be possible, fluid boluses can be possible. So so far, we have 4 patients and 2 on the intervention arm, but we recruited a patient on ECMO, very unstable patient. And there was a lot of update within the first days about the fluid balance target for the day. But after, the protocol worked very well, in fact. No, day 2, day 3, day 4, day 5, there was no issues, you know. And so if the attending physician want to give boluses, there's no problem with it. They just need to update the daily fluid balance management target after they gave the boluses. And then, you know, the patient can be positive for the day. That is not necessarily a problem. So we aim to recruit patients that are very sick, in fact.
Okay, so the set daily balance can change throughout the day, basically based on the evolution of their status throughout. Okay.
Yeah, exactly. There is the initial prescription for the day, and there is a simplified form when they can only update the fluid balance target. So they fill the original prescription for the day, and then there is a sheet with multiple lines where they can update and put the hour. Very simple sheet, and this can be done through phone call or verbal orders, no problem.
Okay. Merci beaucoup.
William, I just had a question about for that Eco-AKI study. So for the VEXUS groups, like what was the starting cumulative fluid balance for each group? Like to what extent was that? Did you have a sense of it based on, you know, that from the outset?
So for the overall group, it was 5.1 liters. And we assessed, but there was the only problem, like I said, those patients were not recruited right after the ICU admission. Sometimes there was multiple days between ICU admissions and the recruitment because they developed severe AKI. So as I showed in the fluid balance section, you know, as long as we go, we come up with very imprecise cumulative fluid balance, sometimes that are even improbable, like 12, 15 liters positive. So when we assessed whether the cumulative fluid balance since ICU admission was associated with individual venous Doppler markers, there was pulsatile portal flow, which was associated with cumulative fluid balance, but the other ultrasound signs were not associated with ICU cumulative fluid balance. And the other thing that was significantly associated with the ultrasound markers was right ventricular dysfunction. And this is also, I didn't talk about it in details, but there is also some questions about whether these abnormal ultrasound markers are more a marker of underlying cardiac function versus fluid balance itself. So there is still some work to do about untangling this relationship.
Thanks.
Thank you for that. Again, thanks, William, for that really fantastic presentation and the Q&A. We are a few minutes past the hour, so I will draw this session to a close. Thank you again, and we hope to see you in person some other day.
Thank you so much for the invitation. Have a nice day. Bye.